I'm going to talk about how do I individualize the fluid therapy and the vasopressor therapy. So when exactly the fluids needs to be started, when do we terminate the fluids, and when to start the vasopressor. So because of the injury, I'll get an extra 5 minutes time. That's what Dr. Rajwardhan has told me. So what does the surviving sepsis guidelines say? I'm basically talking about the septic shock. Okay, so let us not dilute it with other kinds of shock. It says you need to give 30 ml per kg of fluids for a patient who presents to you with sepsis. So what if this patient has already received fluids before he comes to you? Or what if he's already operating on the flat portion of the frank starting form where you can't give any more fluids? What if he has a cardiac dysfunction or renal failure? When you give this much of fluid, it is more harmful. Okay, so in these scenarios, this may not be applicable. It has got a weaker recommendation and a lower level of evidence. So that's why they told in the end personalize. So personalization is the way to go. But before that, we need to know why do we give fluids or why do we give vasopressors in sepsis. Sepsis, there are two components. One is hypovolemia, other one is vasopressor. So hypovolemia can be an actual hypovolemia or native hypovolemia. It can be because of inadequate intake or GI losses, or it can be because of venodilatation, increased venous capacitance, or because of capillary lag. There is a hypovolemia, the fluid needs to be given. Macrocirculation and microcirculation. Microcirculation should not be forgotten. It also helps in microcirculatory recruitment. That's why we give fluids. But what is the basis of giving fluid? It is not to increase the blood pressure. It is to give the oxygen to the tissues. The main basis is oxygen delivery to the tissues. And what is the important thing here is oxygen delivery is determined by, most important thing is the cardiac output. The second one is arterial oxygen. So what I'm trying to say is, it's not the blood pressure, it's the cardiac output what you need to see in this. Okay, so how do you optimize the cardiac output? This is based on the tank, pump and pipes phenomenon. You optimize the preload, that is the tank, you give fluids and increase the venous return. Then you optimize the pump, you increase the contractility, and then finally you optimize the afterload by altering the systemic vascular resistance. So basically you are increasing the cardiac output. And do not forget the microcirculation. Tissue fluid resuscitation also maintains the endothelial microvascular integrity and endothelial function. That's why probably prevents further capillary leakage, and by increasing the cardiac output, it reduces the risk of tissue hypertrophy. Okay. So if you give too much of fluid, you will get the clinician in math. You would have seen these patients in the ICU. If you give too less, you will have hypoperfusion. So both of them lead to organ dysfunction and mortality. You know the famous SOAP study which said that cumulative fluid balance at 72 hours was among the strongest predictor of death. Too much of fluid is bad. Again supported by these two studies in acute lung injury FACT study and the renal replacement therapy FINACI study, suggesting that cumulative fluid balance is bad. So this fluid therapy, why I am discussing about it is because it's a vicious cycle. You need to be very judicious in giving fluids. You start fluids, there will be intestinal edema if you give too much of fluids. There will be organ swelling, intra-abdominal hypertension, which results in oliguria. When there is oliguria, you give more fluids, again the same cycle continues. So you need to break this vicious cycle. That's when you give vasopressors. So I've told you how the fluid helps, but you need to know how the vasopressor helps. So when you give noradrenaline, what it does is it increases the cardiac preload by increasing the venous return, by acting on the alpha 1 receptor. It causes redistribution from unstressed to stressed blood volume. It recruits the microvessels. It increases the cardiac contractility by acting on beta 1 receptor, and it limits the fluid. Okay, so it has a multitudes of function. That's how it helps in increasing the cardiac. So this is the important thing. How to decide how much fluid to be given, when to stop fluids, and when to start vasopressors. Most of us go by these parameters. We used to go by these parameters. Heart rate, blood pressure is not put. CVP, pulmonary capillary bed pressure, SCVO2, lactate, and CRP. See, all these are static endpoints. They are less sensitive, less specific, and less useful than the dynamic tests. So we don't go by these tests for fluid resuscitation because this will only tell us the status of fluid in the patient. It won't tell us whether if I give fluid to this patient, will he respond to that. Okay, this is a good Frank-Starling curve which will explain us. It's a relationship between the preload and the stroke volume. So if the heart is operating somewhere here in the steep part of the curve, if you give volume, the stroke volume will increase. That means it is responsive to fluids. But if the same heart is operating somewhere here on the flat part of the curve, if you, no matter how much ever fluid you give, it is not going to increase the stroke. So that is preload independent. So this part is the one where you have to give fluids. And our static test will not determine this where the fluid will be given. The dynamic index is the one which will tell us where the heart is lying or where the patient is lying, and then we can give the fluids. Understood? So this part is very important. So if you give fluids here, he will respond, and if you give fluids here, he will not respond. So if the patient comes to you somewhere here and you keep administering fluid, you are going to do good. So what is fluid responsiveness? You give 500 ml of crystalloids, there should be an increase in stroke volume by 10 to 15%. So fluid responsive patients will have the preload result. That's why they increase the cardiac rate. See, in all these slides, I'm not telling about the blood pressure. I'm only talking about cardiac output. Cardiac output is the one which is going to increase the oxygen delivery. That is what's going to help the patient. Okay, that's what your fluid therapy is based on. So what are the dynamic indices here? There are some tests or some maneuvers where you do, unlike CVP and pulmonary capillary pressure. Here, before the volume is given, we'll know whether the patient is fluid responsive. Okay. Unlike CVP and other things, you give, we know the change in some, so before we used to use change in CVP. You know the CVP level, give fluid bolus and check for the rise in CVP. But what you're doing wrong there is you've already given a fluid to a patient where he doesn't require fluid. Here, you don't have to give the fluid. You can assess his fluid responsive, then you decide on the fluid. Okay. It is basically underlies the physiology of heart and lung interaction. So these are the dynamic parameters we use. The stroke volume variation and pulse pressure variation. So it is nothing but the respiratory variation, the stroke volume and the pulse pressure where it becomes maximum and minimum along with the respiratory cycle. At the end of inspiration, you can see the pulse pressure and the stroke volume is maximum. At the expiratory period, it is minimum. So this variation is normally there, but in hypovolemia, this variation gets exaggerated. Okay, this is a very important slide. So whenever there is hypovolemia, the stroke volume variation becomes more, or a pulse pressure variation becomes more. When it is more than 10 to 15%, then he is fluid responsive. You can give fluids in it. But what are the problems with this pulse pressure variation, stroke volume variation? You can't use that parameter in these states. If the patient is spontaneously breathing, most of our ICU patients who comes to us initially are patient has cardiac arrhythmias. If there is an ARDS patient who is getting a low tidal volume ventilation or a low compliance patient, if there is an open chest or increased intra-abdominal pressure, or he is very tachypneic, or there is a right heart failure patient, you can't use pulse pressure variation, stroke volume variation. How do you measure this PPV staging? I'm going to tell you in further slides. Basically, you have an arterial line, you connect it to a hemodynamic monitoring device. It will take the arterial pressure, arterial line, and based on the pulse counter analysis, it will give you the stroke volume as well as the pulse pressure variation. Okay. So what do we do when you can't use PPV and SVV? We can use this test, which is a good test which we commonly use in the bedside, is the passive leg raising test. Basically, you increase the leg end, leading to increase the venous return of the fluid to the heart, and what you see is 14% increase of change in VTI. What is VTI? VTI is a surrogate of stroke volume or a cardiac output. I'll tell you in the further slides what is VTI. So you measure the baseline VTI. After passive leg raising test, you check one more VTI, and if there is an increase in 14% increase in VTI, indicates that this patient is fluid responsive. You can give fluids. Okay. So this is actually validated with. It's a good validated this one called maneuver. It can be used in most of the ICUs, and basically you need a cardiac output monitor and echo probe is done. Other indices what we commonly use is IVC indices. You have a ultrasound probe, keep it in the hypocontract region, look at the IVC, 2 cm distal diabetic vein joining the IVC, measure the IVC and look at the maximum and minimum diameter. So in a spontaneously breathing patient, you use collapsibility index. There is a formula for that. If it is more than 15%, he is fluid responsive. In a mechanically ventilated patient, you use the distensibility index. If it is more than 18%, you give fluids. Okay. Similarly, we have other tests like end expiratory occlusion test and tidal volume test. Basically, the same phenomenon. At the end of expiration, you do the expiratory hold, and there is an increase in cardiac output. indicates that fluid response. Okay. But if you remember these ones, that is good enough. Most of the times we get through. If you have a cardiac output monitoring, this is enough. If you don't have it, then probably an echo probe with passive electricity test will suffice. Okay. So what I'm trying to do with dynamic indices is, I'm trying to see whether the PLR will increase the venous return and whether the RV can take it. And simultaneously the same thing, what I'm trying to see is whether the LV can use it by seeing the cardiac output and the cardiac output monitors. And you look at the static indices, you can only see that the RV can take it, that is fluid status. But if you look at the dynamic test, you can see both RV can take it and LV can use it. That means cardiac output is also seen. So this is a better test. That's what I'm trying to say. Dynamic test is the way to go. This is how you measure the cardiac output of stroke volume. You take an apical 5-chamber wave, look at the aortic valve opening and put a pulse wave doctor there, and you get this trace. This is the VTI trace. And when you multiply this VTI with aortic cross-sectional area in the paraspiral long axis wave, you get the stroke volume. And stroke volume into heart rate, you get the cardiac. So always you need not measure the cardiac output of stroke volume. If you check the VTI, change in the VTI, what I told in PLR, baseline VTI to change in VTI, will help you to decide whether the patient is fluid responsive or not. Okay, is this clear till now? So the different methods of measuring the cardiac output, I won't go into detail of that. Generally we use flow track or a Vigilio with arterial line. Sometimes if we have a PICO monitor, we can use a central line and arterial line to look at the hemodynamic parameters. It will give you the cardiac output, cardiac indices, pulse pressure variation and stroke volume variation, and some other parameters which I'll tell you through the slides. Okay. So by looking at all these slides, I will derive this. So if the patient is in septic shock, initial phase I'll give a fluid bolus, not 30 ml per kg. So tailor it maybe 1 liter fluid bolus. Then you look at the fluid responsiveness. How to decide which test? If the patient is spontaneously breathing or cardiac arrhythmias or low tidal volume ventilation, you can't use this. So I will go with passive breathing. Suppose he is already mechanical ventilated and no other contraindications are there, then I'll use probably pulse pressure variation of identity and look at the fluid responsiveness. There is some concept called fluid tolerance also. Now you know the fluid status, you know the fluid responsiveness, and there's something called as fluid tolerance. In the fluid responsive patient, the amount of fluid you give, it will cause harm. How much he can tolerate is called as before it develops an organ dysfunction, it's called as fluid tolerance. And the easy way to know about it is, you have a linear probe, put it on the anterior part of the chest and look at something called as, what are these? Bay lines, indicating more of fluid in the lungs. Okay. And what kind of fluid in the lungs, how do you derive it? That you can do. So this is a bedside test. See, generally we talk about a lot of PLR, PPV, SVV, not all setups have it. The easiest way, a crude way to do it is you give fluids and you keep watching these B lines or look at the SpO2 levels. Gradually the depletion of the SpO2 level with fluid loading, that means you're loading his lungs with fluids. So that's when you decide you have to cut down on the fluids and go for other fluid. Other way to know what kind of fluid in the lung is, if you have a hemodynamic monitoring device, same thing what I told you, PICO or flow track, you can get this. There is something called an extravascular lung water index, which will tell you how much water is there in the lungs. If it is more than 10 ml per kg, that means he's got a pulmonary edema. Pulmonary edema, again you have another indices called pulmonary vascular permeability index. If it is more than 3, it indicates it is a ARDS induced pulmonary edema. If it is less than 3, it is a cardiogenic pulmonary edema. It just guide you regarding what kind of pulmonary edema. Okay. Some of the myths of the fluid therapy. Septic patients are not always hypovolemic. There will be a vasopressor component also. So don't worry, don't think about only fluids. If there is a low preload, doesn't mean that you have to give fluids in there. And if there is edema, the moment you see edema in the patient, you do not give diuretics because they can be still fluid responsive. Okay. And I told you preload is only fluid status, it's not fluid responsiveness. And if the patient is fluid responsive, it doesn't mean that you have to give fluids in them if the organ perfusion is good. Okay. So these are the things which you need to consider before giving fluids. A small thing about MAP, if you ask a lot of people, they say, if you look at the survey also, 60% of the ICU physicians, they follow MAP as the resuscitation target or beginning of resuscitation. MAP is not a universal perfusion pressure. If you look at the traumatic brain injury or any organ injury, you look at cerebral perfusion pressure. Okay. So because MAP cannot be, it cannot give cardiac output or response of fluid increase in cardiac output cannot be determined by MAP because MAP can remain stable over a wide range of changes of cardiac output. So that's what I'm trying to tell you is, if you look at MAP, if there's an acute volume loss, there will be compensatory hypertension. Okay, so there will be high BP, so unnecessarily you will not give any fluids. Likewise, in sepsis, even if you achieve the fluid resuscitation target, MAP remains low sometimes. So you keep on giving fluids and you over-resuscitate it and cause organ. So don't target the MAP. MAP cannot be a target, but it can be a guide for you. It's the cardiac output of the flow-directed therapy is the way to go. So coming to what fluids or which fluids? Surviving sepsis guidelines say balanced salt solutions. What is the ideal fluid? It should increase the tissue perfusion. Result should not cause tissue edema. Should be cost effective and it should be similar osmolarity. And which are the isotonic solutions? Similar osmolarity is normal saline and the balanced salt solution. But what is the problem with normal saline? High chloride concentration, hyperchloremic metabolic acidosis causing acute kidney injury, coagulopathy. But remember, this doesn't happen with the amount of fluids we gave in septic shock. It happens with very high volume loading. Example, in the case of diabetic ketoacidosis patient, we give a lot of crystalloids. That's when a lot of chloride accumulates and causes hyperchloremic acidosis. And ringer lactate has an advantage of electroneutrality. It doesn't have that much of chloride. But if you go by the studies, couple of studies, salt says that there are more major kidney events in normal saline group. But in SMART and BASICS trial, actually mortality wise not much difference. But there was a little bit of subgroup analysis showed 90-day high survival and lesser number of vasopressor days and renal replacement therapy was lesser. But overall, normal saline and balanced salt solution is preferred, but normal saline is equally good. But what about other solutions? Albumin? Albumin should not be used as the first line of therapy in resuscitation. But if you give a large volume of crystalloids, then probably you know that he is going to need a large crystalloids, we can use albumin as a therapy. Starch, no, you have an array of studies here which says absolutely no hydroxyethyl starch because of acute kidney injury and coagulopathy. How much fluids? Go from the history. Dr. Rivers, he started the EGDT, he targeted the SCVO2 and ended up giving more fluids and told that there was actually a risk reduction. But later it was challenged by these three therapies. Process, Arise and Bobby's trial says that it was not useful. Then we dropped the practice of SCVO2 target practice. And these are two important studies which showed that in African children and African subpopulation, giving fluid boluses or more fluids is going to be harmful, increases mortality. So that's the FEAST trial and SSP trial which I discussed. And recently there was Classic and Clover's trial which suggested that there's not much of a difference between liberal and restrictive strategy. So restrictive would do, you don't have to go for a liberal fluid strategy. But the important thing about Clover trial is what we generally tend to do is we keep on giving fluids and we sometimes, not all, but there are some settings where the resources are not good. We delay the administration of vasopressors because we think we have to put a central line to give vasopressors. It's not always true because most of the studies have used and they have proven also, if you give the vasopressor through peripheral line, then that will suffice. But make sure that you use a good bore cannula with cubital vein, use a lesser strength of noradrenaline. Don't use for a longer duration, not more than 4 hours. If the support is going up, then you might have to put a central line. Otherwise, don't delay the vasopressor therapy along with fluid therapy. Nowadays, the recommendation is to start the vasopressor therapy early, why? Because I'm going to tell you later. Another trial where they tried the vasopressor therapy early. Mortality difference was not there, but the shock reversal, target to achieve the MAP was good. And here also 60% of the patients used peripheral line for the noradrenaline use. So if you look at this slide, the fluid infusion, it only increases the venous return and cardiac output, but actually fluid infusion causes decrease in the SVR. Already sepsis, there is decrease in SVR. Why? Because it can cause sympathetic reaction. Other one is it can release nitric oxide for vasoconstriction. So overall effect in the mean systemic pressure is less. But if you look at the vasopressor, it increases the venous return and cardiac output, but also increases the systemic pressure. So mean systemic pressure is more. So what happens if you combine these two? The overall effect is better. The mean systemic pressure is more, corrects hypotension faster. You know the hypotension duration, prolonged hypotension and prolonged organ injury is going to be more detrimental. So you have to correct the hypotension sooner. It limits the fluid overload. Less hemodilution. I told you oxygen delivery is important. Arterial oxygen content is one of the important determinant factors. So if you dilute the blood with fluids, your oxygen delivery will be lesser. It may improve outcome. It's not yet proven. Still you need to do a lot of studies. Look at this slide. 6% is only the resuscitative fluid. 25% is maintenance, rest all are other fluids, fluid creep, the amount of drugs you give in IV fluids, antibiotics, for example, linezolid has so much of fluids in that, blood and blood products, all these things are adding up to his therapy. So that's why you need to have a fluid stewardship in your ICU. You need to consider fluid as a drug, you need to know the dosage, the duration, and nowadays the important concept is de-escalation. We need to know when to stop the fluids and when to start removing the fluids and when to stop the removal of fluids. So that's why this whole protocol has come. So over the days, over the weeks, you need to maintain the U balance or negative balance, and after weeks together, you might have to consider removing the fluids as well. Okay, it's not only giving fluids, you need to look at the removal of the fluids or maintaining the U balance. Last two slides, I want to bring it upon this. The Andromeda shock trial suggested that your capillary refiltering, one of the easiest techniques, looking at the peripheral perfusion graded strategy, you check the capillary refill time, and it can guide you regarding the resuscitation and fluid administration. It is better than lactate levels, and Andromeda shock 2 trial has adopted this strategy. It's a good strategy. Just look at this slide. What they have done is, in a septic shock, they have checked the CRT. If the CRT is abnormal, they have checked the pulse pressure. If the pulse pressure is less than 40, then they check the fluid responsiveness. How do you check the fluid responsiveness? Again, the dynamic indices, they have checked the passive leg raising test and determine the fluid response. Suppose the pulse pressure is more than 40, they have checked the diastolic pressure. If the diastolic pressure is less than 50, indicates profound vasoplegia, they have started norepinephrine. They have not gone on with the fluids. So this is what they have done. They have targeted the CRT, pulse pressure, diastolic pressure, and dynamic indices for PLR. This you can implement in your practice as well. And suppose, in spite of best of fluid therapy and the higher dose of vasopressor therapy, still is not improving, they have looked at the cardiac dysfunction. And if there is a cardiac dysfunction, they have considered adding the inotrones. So what is my practice is, I give fluids based on the fluid responsiveness, and once I know the fluid cannot be given, I will start noradrenaline. Probably I will be more aggressive on starting the noradrenaline therapy earlier. And suppose I reach the noradrenaline limit of 0.3 mics per kg per minute, I will not add adrenaline, I will add a vasopressin. And if it is going beyond, the noradrenaline limit is going above 0.625 mics per kg per minute, then that's when we decide we stop on noradrenaline. Along with noradrenaline, we continue with adrenaline also. In spite of that, there is no improvement, then probably consider local. So, coming to the same thing what I said in the beginning, the one size fits all approach. We started with reverse with EGDT. May be convenient, but it should be avoided. Personalized fluid management is the way to go. Use your dynamic indices, use your capillary refilling time, use your bedside ultrasound techniques, look at the B lines, echocardiographic, IVC parameters, and guide the fluid therapy. Do not wait for the central line to the vasopressor therapy. Secure a good peripheral line, start early vasopressors and improve the blood pressure. Do not target the mean arterial pressure or the blood pressure, go for cardiac or pulmonary strategy. And always follow the fluid stewardship. And if you follow your fluid resuscitation adequately, you won't end up in this kind of scenario which happened. Okay. So, thank you so much.